In this lecture, we will discuss sinus arrhythmia and how it would appear on the EKG. Sinus arrhythmia is defined as any variation in the sinus rate. It represents the normal respiratory pattern and is seen in almost all individuals regardless of age. In fact, the absence of such rate variability is considered pathologic. Furthermore, the heart rate variability has been extensively studied for its ability to predict prognosis in a number of medical conditions. Now, sinus arrhythmia is more common in young, healthy children. The incidence tends to decrease with age, which has been attributed to an age-related decrease in carotid distensibility and baroreceptor reflex sensitivity. So as we've said, this is a normal physiologic phenomenon in which there's that beat to beat variation, okay? And with this beat to beat variation, we can see that the P to P interval, the R to R interval, and the TP interval are going to vary, okay? So what we're going to do now is go through the chart so we don't miss anything. So again, we're saying there's a variation in the sinus rate. So that's the main thing, is this variation in the sinus rate. And because of that, we have an irregular ventricular rate. So what we'll see here is that our intervals are not consistent throughout the whole rhythm, okay? And we're saying, again, this is a sinus rhythm, so it's going to originate from the sinoatrial, the SA or sinus node. Remember, this is located here. Okay, there's our sinus node in our upper right atrium. Okay, this is our right atrium. We're saying what we're going to learn is what really defines the sinus arrhythmia is a P to P interval variation of greater than 160 milliseconds. Okay, and we'll see that's 4 small boxes. Okay, so that's our main variation. Okay, so while there's variation in all individuals, it's this what really defines and what gives us the diagnosis of sinus arrhythmia. Okay, we'll see that shortly. So again, all these intervals, the P to P, R to R, and TP intervals will vary slightly, but if it goes beyond this 160 milliseconds, then we get this diagnosis of sinus arrhythmia. So let's start with the regularity. Well, the regularity with this arrhythmia is regularly irregular. Okay. And why is that? Well, this has to do with the variation in respiration, okay? So what we see here is that with an increase in vagal tone, just in general, we see a decrease in heart rate, right? As we increase parasympathetic activity that acts on the sinus node, it will lower the heart rate, okay? What happens during inspiration is that there's a decrease in vagal tone, and as a consequence of that, we get an increase in heart rate, okay? And as we expire, as we let air out, the vagal tone returns to normal, okay, and relatively increases from what it was, and because of that, the heart rate will then decrease. Okay, so that's what's going on here. And we said this is an irregular rhythm, okay, because if we were to measure our intervals out, you would see from this P wave to this P wave, so this is our P wave and this is our next one, okay, that interval from P to P interval is different from the one that follows, okay, from this here to the next, okay? But this P to P interval, P to P prime we're calling it, is the same as the one that follows. And what you'll see if on an EKG, if you had this whole 10-second strip, is that you'd have these intervals that would be somewhat regular. So we'd have P to P intervals that would be the same for a few beats, and then we would see variation, okay? And because of that, we call this a regularly irregular rhythm. So it's an irregular rhythm, but overall, it has some regularity to it, okay? Hopefully that makes sense. Now, in terms of the rate here is coming from the sinus node, so it's going to be between 60 and 100 beats per minute. Now remember, we're dealing with an irregular rhythm. So do you remember how we find the rate of an irregular rhythm? Well, imagine that we have our EKG, okay? We'll put, these are our 12 standard leads, and then maybe we have some rhythm strips at the bottom. When we look for the rate of an irregular rhythm, we want to make sure we realize that the duration of the EKG, the standard EKG, is 10 seconds. So if we multiply that by 6, we get 60 seconds, okay, which is 1 minute. So what we would do is if we were to count the complexes going across, so imagine we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay, so imagine 11 complexes going across. We multiply that by 6. That gives us a rate of about 66 beats per minute. Okay, and we would do that because all these intervals between them would not be consistent. Okay, so that's why we use this method in finding the rate. Okay, but again, the rate should be between 60 and 100 beats per minute. Now, in terms of the P waves, we'll see sinus P waves, okay, because it's originating from our sinus node here, and they'll be present, and they'll have a constant morphology, meaning they'll all look the same. They're all coming from the same location, so they'll have the same morphology. Now, in terms of the axis, again, because it's coming from the sinus node, remember if we go over our conduction system, we have our sinus node, our internodal pathways come to our AV node, we have our Bachmann bundle coming to the left side. From our AV node, we have this His bundle here, okay, that splits off into a right bundle branch. And then we have our left bundle branch on the left side of the heart. And then the left bundle branch divides into a left anterior fascicle and a left posterior fascicle. And these fascicles and the bundle and the branches on the right side innervate the go to the ventricular Purkinje fibers, which then innervate the myocardial cells, and then we get the transmission spreading by that means. So what we're saying here is we're starting in our sinus node, okay, and we're heading towards our AV node, okay, to our AV node, and because of that, the direction of our axis is between 0 and positive 75. So this is a normal P wave axis, okay, in the frontal plane, going leftward to the left, right? This would be the right, and it's going, again, inferiorly. Okay, so hopefully that makes sense. Notice the way the direction it's going. In terms of the configuration of the P wave, we'll see upright in 1, 2, V4, V5, and V6. So why is that? Well, let's look at the leads. Lead 1 would sit here. Lead 2 here at positive 60 degrees. Then we have V4, V5, and V6, the left lateral precordial leads sitting horizontally. Okay, and because notice the arrows heading in those directions, we'll see upright positive P waves in those leads. So you can imagine maybe this is a lead 2, or it could be lead 1 or one of those leads. In terms of AVR, which sits here, it's going in the opposite direction. So in AVR, we'll see inverted or negative P waves. In terms of V1 and V2, okay, those are their right precordial leads sitting anteriorly. So imagine V1 and V2. Again, let's just erase some of this here. What we have going on is, remember, there's that initial impulse, the right atrial depolarization. So the impulse will come in. Remember, the right ventricle sits mostly anterior, so the initial vector from right atrial depolarization will head towards those leads, okay, in this direction, towards V1 and V2. And what we'll see because of that is that it will be positive. So we can see positive, we can see inverted, and then we can see these biphasic positive, negative, okay? The initial portion that's positive represents right atrial depolarization because it's heading towards that lead, okay? And then we'll have depolarization going pretty much posteriorly, okay? So imagine these are anteriorly, now it's heading posteriorly, and that's why we see this negative deflection representing left atrial depolarization. So we consider our right precordial leads V1 one of our short axes because it gives us a good idea of what's going on in the atria and can give us an idea if there's any atrial abnormalities, okay? Now in terms of lead 3 in AVL, there tends to be variation related to the respiratory cycles, okay? Now, in terms of the P wave to QRS ratio, this is a 1-to-1 ratio, meaning that there's one P wave for every QRS complex. So let's just erase that and show here. Okay, so imagine we have a P wave in our QRS, another P wave in a QRS, and you would see this same thing throughout, okay? And why is that? Well, our P waves are firing, our sinus node fire, and everything is getting through to the ventricles, okay? Imagine everything below representing ventricular depolarization, our QRS complex, and above our P waves, okay? So it's getting through, and we're seeing both happening. There's no block at the AV node or anything. In terms of our PR interval, okay, our PR interval, imagine this is a P wave, a QRS complex, and our T wave. The PR intervals from the beginning of the P wave up until our QRS complex. This should be normal in duration, okay? Everything's happening starting at the sinus node and again going to our AV node, all right? Remember, the PR interval, most of it represents AV nodal conduction. It's normal here, so we have no issues. So it should be constant, normal throughout between 120 and 200 milliseconds in adults. The QRS interval, okay, which again, the QRS intervals from the beginning of our QRS complex to the end of it should be normal in this case. Should be between 70 and 110 milliseconds, which is about 2 to 3 of the small boxes. And why is that? Because everything below in our ventricles is happening normally. We have normal intraventricular conduction, okay? So no issues there. In terms of grouping, there doesn't seem to be any appearing, there's no grouping, so we don't see certain waves or complexes occurring together, and there's no drop beats. Every beat that makes it from the sinus node gets through the AV node into the rest of the conduction system, okay? And remember what the variation is, and let's just look at that here, is that gives us the sinus rhythm is that greater than 160 milliseconds between the P to P interval. Okay, so if you look here, notice our P wave starts at this line, okay, and it goes to the next P wave there. So there's 1, 2, 3, 4 thick lines between that, and then we have a new P to P interval happening the next 2 rounds. So here's our P wave starting at this one, okay, and it goes until here. So that'd be 1, 2, 3, 4, 5. Okay, so 4 to 5. Okay, you would expect it to occur here in normal sinus rhythm, but it's occurring after. Okay, and from here to here represents 200 milliseconds. Okay, which is greater than that 160 milliseconds. So this is actually sinus arrhythmia. And if we were to look to the next P to P interval, okay, here's our next P wave. 1, 2, 3, 4, 5. Okay, so it's again the same duration between. So there is some regularity to it, but overall it's irregular. Okay, and that P to P interval variation is above 160 milliseconds. So that's what gives us and defines that sinus arrhythmia. All right, let's briefly review what we discussed before we end here. So sinus arrhythmia, the only thing that's different from normal sinus rhythm is this variation in the sinus rate, okay? That results in this irregular ventricular rate that we see, okay? And because of that, the intervals will vary. And again, remember, this is originating from our sinus node. It's a sinus arrhythmia. The thing that defines it is that P to P interval, okay, greater than 160 milliseconds. So remember, 160 milliseconds is 4 of those small boxes, okay? So again, this is a regularly irregular rhythm that varies with respiration, okay? So during inspiration, the vagal tone drops, so we'll see an increase in heart rate, okay? So imagine this is a faster area. So this part could be during inspiration, where things start slowing around here, okay, and the intervals get wider, the heart rate starts to decrease. This could be during expiration, okay, as the vagal tone returns to normal, increases relatively to inspiration, and we get a decrease in the heart rate. The rate should be between 60 and 100 beats per minute. Remember how we found that? We count the complexes going across, multiply that number by 6 to get us to beats per minute, okay, because we're dealing with that irregular rhythm. The P wave axis should be the same as the normal sinus P waves, okay, constant morphology, axis between 0 and positive 75 degrees, heading leftward and inferiorly. Configuration should be the same, upright in 1, 2, V4 through V6, inverted in AVR, and then again in V1 and V2 could be upright, inverted, or biphasic. If it's biphasic, remember it should be positive and then negative. The P wave to QRS ratio is normal, 1 to 1. The PR interval, okay, there's normal AV nodal conduction, and it should be between the 120 and 200 milliseconds. So that's 3 to 5 small boxes. The QRS interval should be normal, between 2 to 3 small boxes, okay, which is about 70 to 110 milliseconds. There's no grouping and no beats are dropped in sinus arrhythmia. Well, that's the end of this lecture. We discussed sinus arrhythmia and how it would appear on the EKG. I hope you learned something.